Welcome to Stago Educational Shorts. Short lectures covering the essentials of key coagulation topics. Presented by world-renowned experts. And designed to fit around your busy schedule.
Thanks for joining us today at this Stago Educational Short. Today we're joined by Anna Lowe. Anna is the Senior Lead Scientist at UK NECWAS for the haemophilia programs. She has 10 years of experience in the field of hemostasis and thrombosis. Today she's going to be discussing the challenges posed by heparin-induced thrombocytopenia and its diagnosis from the perspective of EQA. And we'll join Anna now.
Hi, my name is Anna Lowe and I'm Scientific Lead for Haemophilia Programmes at UK NECWAS for blood coagulation. And today we're going to talk about heparin-induced thrombocytopenia or HIT. So this is my disclosure slide. So you're probably quite aware of HIT, especially within the latest, say, 6 to 18 months due to COVID-19. There's been a lot of HIT documentation within the media. However, I'm not going to touch on that today. It's just going to be a basic overview of HIT, and we're going to look at the exposure, the mechanism of action, clinical diagnosis, laboratory diagnosis, moving on to treatment, and then I'm going to go through some UK NECWAS surveys that we do here at NECWAS. So this is a basic overview, just linking everything together. So exposure for patients is usually through heparin administration. This leads on to pathophysiology, which gives an antigen-antibody complex and then platelet activation, therefore leading to symptoms of thrombocytopenia, atrial or venous thrombosis. Diagnosis of HIT is quite a complex method. And when I say complex method, you do need both clinical scoring and laboratory assay testing results in order to give then adequate treatment. And treatment usually is the stopping of heparin and alternative anticoagulation methods. So pathophysiology of HIT. It's usually classed as type 1 or type 2. Type 1 is quite a mild non-immune response where heparin and circulating antibodies cause clumping and very mild thrombocytopenia. Type 2 is a much more aggressive method where it's an immune-mediated response to heparin binding, and the heparin binds to platelet factor 4, leading to formation of IgG anti-PF4 heparin antibodies, and therefore platelet activation and a very high prothrombotic state for the patient. This then leads to the symptoms that you will see, which are those shown on this slide. So we've got arterial gangrene, deep vein thrombosis, skin necrosis, and plaques throughout the body. So as I mentioned previously, diagnosis is a very complex methodology. So clinical scoring is required and as well laboratory assay tests. So just focusing here on the clinical scoring is classified as a 4T scoring system for suspected HIT. And when I mean 4T scoring system, it's a characterisation of the different areas of HIT. So for instance, thrombocytopenia, timing, thrombosis, and then other causes of thrombocytopenia. So whoever's looking after the patient, so the clinician, the doctor or the nurse in charge, will look at the patient's symptoms, look at the lab tests that are returned, and then give them a score accordingly. So an example, for thrombocytopenia, if their platelet count falls more than 50%, they would then get a score of 2. Going through this 4T scoring system, if the patient is scored less than or equal to 3, this indicates a low probability of type 2 HIT. If, however, the patient is scored 6 or more, then this is association of a high risk of HIT. So laboratory testing Possibilities and challenges. Majority of the laboratory tests are immunological tests. There are functional tests that can be used, however these are very specialised and are only used in certain specific reference laboratories. Within the immunological assays, there's a very large variety of different assay methods that can be used. So these are the four main immunological assays. We've got the ELISA or enzyme-linked immunosorbent assays, the particle gel immunoassays, lateral flow assays and automated chemiluminescent ones. They've all got their disadvantages and advantages. So for instance, the ELISA method and the lateral flow assays have a high level of sensitivity, whereas the particle gel immunoassays and the automated chemiluminescent are very fast and can be used throughout urgent testing for the patient. So functional assays, these are classified as the gold standard for HIT testing. However, like I've mentioned before, they're not very widely available throughout a lot of hospitals, and they are only really found in specialist reference labs. And these really do include the SRA or the serotonin release assay and the HIPAA or the heparin-induced platelet activation assay. Both of these have very high specificity and sensitivity and are usually referred to as the gold standard for testing in HIT. So treatment, usually it's the withdrawal of heparin straight away, and this will include catheters and any heparin containing flushes that are within or contained by the patient. Then you've got initiation of non-heparin anticoagulation, and depending on the renal or hepatic function of the patient will obviously depend on what the patient is administered. Usually it's argatroban, and these can be used in combination together, so argatroban and leparudin, depending on the specific needs of the patient. So now just moving on to what we do here at UK NEQAS within relation to HIT surveys. Our HIT surveys are sent to participants typically once a year, and this will depend on the requirement of what our participants need. Usually it's 2 samples and distributed per survey, and again this depends on the clinical scenario of the sample itself. Instructions and results are distributed within the pack. The participants have 4 weeks to complete and return results. In-house analysis is then performed and results are issued 2 to 3 weeks after analysis. So once the analysis is performed, the participants are peer group median assessed. Any reported result issues that are highlighted within the results that are reported will obviously be fed back to the participants. If any issues we feel that need to be investigated, internal investigations are then performed, and then we will pass again this information on to our participants in order to highlight these issues. So an example of one of our HIT surveys, here we've got on the screen results that were taken from a survey back in 2018. The details within the table show a variety of ELISA methods which are used by participants and their results that they reported. As you can see, majority of the participants using the ELISA method reported that the sample that we sent out to them, coded S1801, was negative. However, one type of assay that was used by 12 participants was shown to be positive. So obviously we identified a variation of results among different testing methods. This discrepancy was reported back to the peer groups, and the sample that we sent out, before we sent it out, was identified as having raised HIT antibody levels by the ELISA assay as we did some internal testing. So within conclusion, we provided further internal investigations to look at the specifics of each of the ELISA testing methods. And we kind of came to conclusion that some assays are highly responsive towards the presence of only the pathogenic HIT antibodies. So we wanted our participants to know to be careful when consideration of laboratory results and to make a diagnosis, and therefore this increases the quality of the patient care. So I would say that standardising testing is quite a challenge, as we saw within the example of the presentation for the NEQAS survey 2018. And I think we've got it down to a T with using both clinical and laboratory assays in order to standardise any tests or any new to the market tests that come along, whether that be lateral flow testing, whether that be automated chemiluminescent testing. And I think for people to participate within our UK NEQAS surveys, it just helps to give that information back to people, back to participants of the standardisation that we can achieve and offer. Ideally, it would be a one-size-fits-all test, gold standard, functional assay that could be easy to use, not very expensive, doesn't require platelets. However, that might be a way off yet. So I think what we've got currently and what hospitals and laboratories have got set up does work. Firstly, I would say get in contact with us here at UK NEQAS BC. Then we can always send a second sample out and for you to test that, and then we can give you further advice when you've sent your results back, whether any issues firstly would have been user error, or whether you've got a calibration issue, whether you've got a quality control issue. And we would also strongly advise you to go back to the manufacturers of that specific test or assay method and to seek their advice as well, because they can offer you an array of information that they've dealt with participants or patients or lab staff to give you that information of what problems may arise. Thank you very much for listening, and thank you for Stago for letting me educate people.
Thank you for watching the Stago Educational Short. You can find other presentations by world-renowned experts on similar topics at www.stagowebinars.com. To learn more about the field of hemostasis and thrombosis, download iHemostasis from the App Store or Google Play Store onto your tablet. iHemostasis is a global education tool dedicated to the pathophysiology of blood coagulation, illustrated by clinical cases, designed for everyone from clinical professionals to students. You can also sign up to our newsletter to keep up to date with the latest scientific topics, educational materials and giveaways at stago-uk.com. For answers to the most important coagulation questions, listen to our Ask Stago podcast, available on all popular streaming services. You can also submit your questions by email at ask@stago.com.